and a hearty welcome to all the dignitaries of IMA MSN and my fellow participants, both in Zoom and YouTube. Welcome you all to the clinical case presentation series by IMA MSN. I would like to introduce myself. I am S. Prasanna Kumar, Joint Secretary of IMA MSN from Basveshwara Medical College, Chitradurga. Now, I would like to introduce the dignitaries of IMA, Dr. Karnakar sir, Dr. Srinivas sir, IMA President, Dr. Subrata ma'am, Chairman of IMA MSN, Dr. Shantala ma'am, Academic Chairman of IMA, Madhusudan sir.
We'll continue the IMA prayer.
I would like to hand over to Subrata ma'am to start with IMA prayer.
Yes, thank you. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you.
Thank you, ma'am. Now I would like to hand over to Madhusudan sir to introduce the moderator.
Sir, Madhusudan sir.
Yeah, good evening all. And on behalf of IMA KSB, I welcome all the students and the members of IMA MSN and also the leaders of IMA Karnataka State Branch. Here is with us Dr. Subrata. She is our IMA MSN State Coordinator for us. To introduce Dr. Ramesh Reddy, he is my classmate from Ballari Medical College. Did his MBBS from Ballari Medical College, and presently he is professor and head of the Department of Surgery, Vaidehi Medical College, Bengaluru. And he has got vast knowledge of teaching undergraduates and postgraduates. And he is a very, very busy surgeon, but accepted our request to guide the students. And he is attached with Rajiv Gandhi University also. Definitely, he will be a guiding force for the students. And here I welcome Dr. Ramesh Reddy. Reddy, over to you.
Yeah, thank you, Dr. Madhu. It's a great privilege, and I'm really honored to be here today. When Madhu told me that I have to moderate a session, I was so glad that I've been given an opportunity to do this. And I'll be of any help for any way, because even we are part of Board of Studies at RGHS, and I'm ready to help any guidance for our undergraduates and postgraduates. They can reach out to me anytime. And yeah, that's it.
Thank you, sir.
Yeah.
Now I request Krupa ma'am to introduce the presenter.
Good morning all. Sorry, good evening all. And I'm glad to have my very own friend. I've known him since PU, and one of the most excellent student in our class, and Dhanush P. So we're very happy to have him as our presenter today.
Thank you, Krupa. Good evening, sir. Good evening, everybody. Myself, Dhanush. I am a final year student at KIMS Bengaluru. Today, I'll be presenting the case discussion series on hernia. Shall I begin this slide presentation, ma'am?
Yes, start it then.
Yeah, is my slides visible?
Yes.
Shall I begin, sir, Ramesh, sir?
Yeah, we can start.
I hereby
I
present a case of XYZ, who is 50 years old male, who is farmer by occupation and who resides in Banshankari second stage. He came with the chief complaint of swelling in the left groin since 2 months, history of presenting illness. Patient was apparently asymptomatic 2 months back when he developed swelling in the left inguinal region since 2 months. Swelling was spontaneous in onset on straining, first appeared in the groin and gradually increased in size, initially noticed 3 into 3 centimeter approximately to present size of 10 into 10 centimeter approximately, and now extends to the scrotum. Swelling increases in size on coughing and straining and relieved on lying down. However, since last 1 week, patient feels he needs to gently manipulate it for complete reduction in size of the swelling. Swelling is associated with dull aching, dragging pain since 2 weeks. There is no history of gargling sound in the swelling or scrotum. There is no history of abdominal distension or vomiting. There is no history of chronic cough. There is no history of constipation, altered bowel habits, tenesmus, and bloody stools. There is no history of uh, swelling on the other side, or there is no history of urgency, hesitancy, or altered stream, or burning maturation or hematuria. Yeah. Past history. There is no history of similar complaints on the same side or other side. There is no history of hypertension, diabetes mellitus, coronary artery disease, tuberculosis, asthma, COPD, or blood transfusion. There is no history of appendicectomy. There is no history of previous medical admissions. Family history. None of the patient's parent, siblings, or first degree relatives have or have had similar complaints or any other significant comorbidities. Personal history, your diet was mixed and appetite was normal. The bowel and bladder habits were normal and regular. Sleep was normal and habits were none.
Okay, stop. Now, with this history, what is your conclusion?
Sir, based on the history, here comes a 50-year-old male with the chief complaint of swelling in the left groin since 2 months. So suggestive of um, there is some the swelling might be due to hernia, sir.
What makes you say it is hernia? Can you define hernia, please?
Yes, sir. Hernia is abnormal protrusion of the viscous or any content through the defective wall.
Effective wall. Where?
Sir, here in this
To
case, it's abdominal.
no definition. It should be complete.
Yes. The hernia is defined as a protrusion of the viscous or
Part
any
or the
content.
whole of the viscous through the
Right.
walls of the cavity containing it.
Yes.
Right. That's it. That's all.
Hmm.
Now, can you elaborate on each one? What you asked for? Swelling, spontaneous in onset on straining. What swellings will appear spontaneously on straining?
So, because usually hernias appear spontaneously on straining because of raised intra-abdominal pressure. The hernia is the risk factor for hernia is based on the raised intra-abdominal pressure. On straining, there will be raised intra-abdominal pressure, sir. So I would think of hernia. It points more towards hernia.
What else can be there? What other swellings will appear spontaneously on straining?
Mm. Not very sure, sir, because usually swellings over there, like you could expect differentials as lipoma or any tumors of the abdomen, mass abdomen.
Mm.
But usually they will be persistent. They don't like uh onset will usually not based on straining. So I would think of directly to hernia, sir.
I would request Dr. Madhu and other surgeons, if you're there, also to participate.
Yeah, ready. We are with you.
Yes,
Let
Madhu.
the students answer.
Yeah, Madhu?
Yeah, let the students unmute and answer. Let
Yeah,
them
yeah.
answer.
Yeah.
That will be better, I feel.
No, we can ask questions in between if that is so.
Yeah, definitely.
No history of gurgling sound in the swelling or scrotum.
Yes, sir. I would just
Yes.
avoid the negative history part, sir.
Why did you ask for look for gurgling of sound in the swelling or scrotum?
Sir, usually whenever there is visible, like whenever the intestine is the content of the hernia or the swelling, usually there might be history of gargling sound. So that may be the.
No. Again, you should be clear on that. See, it can be the content can be intestine, can continue momentum. Now, before that, I would like to know why you came to the conclusion that it is hernia. What are the other things that you can think of when you're presenting a case like this?
Sir, other differential diagnosis for hernia, as I said, other abdominal masses can be the differential.
Yes, can you tell me one by one and tell why it is not?
Okay. Sir, any mass abdomen like gastric outlet obstruction is where there is a oval shaped mass. And,
No. Gastric outlet obstruction is in the abdomen.
yes, sir. In the inguinal
It's the
region,
inguinal region.
lipoma, sir, lipoma, it doesn't,
Okay.
lipoma, it doesn't move on, like there is no onset of onset on straining. So
There is
that,
no increase or decrease in the size of the swelling. Okay.
and other, any cystic swelling over there.
Like,
Um,
see, you should not be biased in exams. No, you'll be biased. You'll be straight away telling, yeah, because you know the diagnosis. You will be focusing only on these things. You are not thinking about the other swellings.
yes,
The
sir.
problem is, we will be asking you other. We know that you know the case very well, and we know that you'll be coming prepared. So you should be ready to answer whatever we are asking, maybe from the other side. We would like to test your knowledge broadly rather than you knowing only one case.
Yes, sir.
What is saphenavarics?
Saphenavarics is the varicose of the saphenofemoral junction where the opening has the defect, so there will be bulging of the veins, sir.
Yeah. No, that we'll talk about is the differential diagnosis. Here, history of present illness.
Ready? Ramesh? Ramesh?
Yeah.
Yeah. Switch on your video. We want to take a screenshot.
Ayyo.
You will have record. Yeah.
Danish, carry on, Danish.
Yes, sir. I'll
Why
continue.
did you ask for history of abdominal distension, no history of abdominal distension or vomiting?
Yes, sir. Abdominal distension, again, I wanted to rule out any abdominal masses which may be intra-abdominal pressure or may present as a swelling over there. And vomiting, again, obstruction, any intestinal obstruction or obstructed hernia itself can present with the vomiting.
Okay.
Even Dhanush?
Yes.
Abdominal distension also could be one of the symptom of obstruction, irreducibility.
Yes. Generalized peritonitis.
Every history has to have a reason behind it. Yeah,
Yes.
what Dr. Ramesh was telling that don't go with the presentation with biased diagnosis. Hernia is a you think very easy case, but very difficult to pass. That's what we were taught.
That was hernia was my case, the Bodhu in the examination.
Yeah.
It was so tough. We thought so easy. The questions asked were so difficult, probably because our teachers in Ballari was only our library. We used to read a lot of books and learn by ourselves. So that way, by discussing, we learn a lot. Don't be biased. Only one thing. Yeah, this is this. No. When you start talking with your friends, see, talking and studying with your friends is very important. I'm just going out of the thing, giving you small tips about how to go about it for your exams. It is always discussion. Go every day to the rods, see cases, get your friends along. Even after 4 o'clock, go do rounds. It is not like even units you'll be telling, this is my unit, I'll not see other unit cases. No, look after all the cases. See, your distribution of units is only for convenience. All cases are your cases. I would like to tell all students this, that all cases admitted in the ward, irrespective of the units, should be seen. They are all your cases. It is distribution only for convenience of management of the patients. So I would like to tell you, after 4 o'clock, just go around the wards, see all cases and discuss. This might be a hernia, which you think is easy, right? It can be difficult. It can be, again, by discussing, you will come to know so many things. This is just my advice, which I'm giving you. Don't be focused in only one thing with your preoccupied diagnosis.
Yes, sir.
Why did you ask of history of cough?
Yes, a chronic cough and constipation or altered bowel habits. Again, it points towards the increased intra-abdominal pressure, whereby there is
Okay.
a factor for swelling in the groin region again.
Next, history of urgency, hesitancy.
These are to rule out any bladder outlet obstruction, whereby there can be urinary retention. Again, it can raise the intra-abdominal pressure, whereby there can be increased risk of hernia.
Swelling on the other side.
To rule out, sometimes usually there can be presentation of bilateral inguinal hernias. So
Is it only hernias?
again, you have to rule out for any swellings around. The multiple swellings will again point towards different diagnosis.
Okay. Continue.
Past history. There is no history of similar complaints in the past, and there is no history of hypertension, diabetes, whereby I'm ruling out all the comorbidities. And asthma, and particularly COPD and respiratory illnesses, are to be ruled out. Again, they precipitate for the chronic cough and thereby raise the intra-abdominal pressure, which is a risk factor. And no history of appendicectomy was asked because during appendicectomy, the most common nerve to be injured is ilioinguinal nerve, thereby which can lead to weakening of the posterior abdominal wall.
What
Until
does it supply? What does it supply?
sir, it supplies the for the muscles of conjoint and internal oblique and transversus abdominis.
Okay.
And family histories are again sometimes there can be congenital connective tissue disorders or muscular disorders which are prone for again swellings like this. And personal history was asked again to rule out all the bowel and bladder, and habits especially points towards smoking. We have to note because again in the smokers there is an increased risk of hernia because of collagen breakdown due to imbalance between the metalloproteases and the collagen synthesis. So thereby there can be the weak fascia through which the abdominal contents can protrude.
Sleep habits. Okay. Next, continue.
Shall I continue with?
What's his occupation? Would you like to
Yes, sir.
comment on his occupation?
Yeah, it's farmer by occupation, sir. Again, you can also think that based on the occupation, whenever there is a history of heavy lifters, heavyweight lifters, again, and sports person can usually are also prone for hernia, sir.
Why?
Because of raised intra-abdominal pressure, again, because that will lead to the risk factor again.
Why do you think not everybody in the gym will get hernias? Everybody who lifts weight will get hernias. You see so many people lifting weights and putting into lorries, tractors, and all that, no? Daily wage workers.
Long term, they are prone for it, sir. Needless, they're more prone for it rather it will directly cause it. It is a mixed multifactorial, sir. Actually, there is a occupation as well as there is a congenital weakness. Again, it runs through the family.
No. What is the cause for hernia?
So,
What is the cause for hernia?
in this case,
Not everybody who lifts weight, not everybody who coughs will get hernias, right?
yes, sir.
In whom do you think it is?
More like inherited muscular.
No, no. Can you be a bit more? What is processus vaginalis?
Patent processes which sir, it's
Yes,
abdominal during the during the embryological development of the external genital.
yes. Only in whom there is patent processus vaginalis will this hernia occur, isn't it? Not everybody will be getting it.
Yes.
That is the cause for hernia, actually. The patent processus vaginalis is the cause for hernia. Yes, continue.
I'll continue with the general examinations.
Yes, yes, yeah. Yeah.
General survey, a 50-year-old male patient who is supine depicutus, who is well built and nourished, is conscious, coherent, and cooperative, and well oriented. There is no evidence of pallor, hiatus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. On vitals, pulse rate 78 beats per minute, regular rhythm, normal volume and character. There is no vessel wall thickening. Blood pressure 130/70 mmHg in the right arm in sitting position. Uh, Respiratory rate was 16 cycles per minute and abdominothoracic type. Temperature was 98.98 degree Fahrenheit. uh, Local examination. After taking informed consent, patient is exposed from umbilicus to mid-thigh level and examined in both supine and standing positions. On inspection, description of swelling, size
No,
of
just yeah,
yes,
see now you're told it both in supine and standing position.
yes,
Now you have to tell us first is standing position, right? You haven't told anything about it. Now when you're doing inspection here, first I'd like to make the patient stand and then examine. You have to tell the position where you're examining.
okay, sir.
Yes.
Uh, on inspection, first the
Mm.
patient was made to stand and examined on standing position. The swelling appeared was a size of 10 into 10 centimeter. It was pyriform shape and it was located in left groin, which was extending from mid-inguinal point to just beyond the root of scrotum. And swelling appears to be above and medial to pubic tubercle. It appears on a smooth surface and also all borders were well made out and skin over the swelling appears normal and impulse and coughing. There was visible expansile cough impulse seen. Penis was deviated to right and there is no scar, sinuses or engorged vein or visible peristalsis seen.
See, you have to use your discretion now. When you're telling swelling is above and medial to the pubic tubercle, where is it extending up to? It is just in the inguinal region, isn't it?
Yes, sir. It
Then
just
why?
joined the
Yeah,
root of scrotum.
just at the root of the scrotum.
Yes, sir. Just go passing beyond it does not descended till the base of the scrotum. It is in between.
Okay. Why did you ask for scars, sinuses, engorged veins, visible peristalsis?
Sir, again, scars to rule out any muscular initiation or rule out incisional type of hernias. And engorged veins can be to rule out
Incisional hernias in this groin. Previous surgery. You mean to say previous surgeries?
a previous surgery.
Previous hernia repair or okay. Then
And
sinuses. Where do you see sinuses?
sinuses can be cold abscess. Sinuses can not
Tubercular epididymitis.
yes,
Hmm?
tubercular cause.
Okay. Engorged veins.
Um, sir, again, whenever there is abdominal mass or whenever there is a raised intra-abdominal pressure, it can compress over the veins of the
Hmm. Hmm.
the lower abdominal region and can cause engorgement of veins.
Can be varicocele also.
Yes.
Visible peristalsis.
To rule out intestine as the content of the hernia.
Okay.
On palpation, it was examined on standing, sir. There is no local rise of temperature and tenderness. And again, the description of swelling, which was all the findings of the inspection was confirmed. And again, I'll repeat, sir. Site was left groin. It was 10 to 10 centimeter. It was piriform shape. It extended from mid-inguinal point to just beyond the root of scrotum. Surface was smooth. Skin over the swelling was also normal. Consistent Consistency was soft. Reducibility, yeah, complete with a little manipulation. Initially difficult, later it was easy, and unable to get above the swelling. So on cough impulse,
Yes.
expansile cough impulse was felt. Special test.
Okay. No. Go back. Go back. Go back.
Go to inspection, sir.
Go up. Next.
The
Next. 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 Yeah. How do you look for reducibility?
Sir, either by lying down,
Hmm.
it reduces itself, or sometimes we can ask the patient himself to reduce the swelling because he knows better how to reduce it.
No, here again, if it goes out easily inside or with manipulation, again the later part will be difficult. Is there anything that you get to know with these tests?
Yes, sir. Because whenever first part is difficult and later part is easy, is seen in case of intestine as the content of hernia, sir. Whereas
Enterosil.
enterosil, and whereas in case of omentocele, where the
Hmm.
oment initially it will be easy, but later it will be difficult to push it back.
Okay. Yes. Unable to get above the swelling?
To rule out congenital hydrocele, not at this,
Congenital.
uh, to rule out differential as an hydrocele.
So vaginal hydrocele and hernia. How do you differentiate by
Sir,
this test?
basically, jet over the swelling is to rule out between the scrotal swelling and inguinoscrotal swellings.
Yes.
I meant to say.
Good. Next.
Special tests. First test was deep ring occlusion test. After reducing the contents, patient in the standing position will occlude the deep ring with the thumb and ask the patient to cough. So the swelling does not appear on coughing here, sir. And next test was Siemens technique, three
No,
finger.
what happened here? What happened here?
The swelling did not
Did
appear.
not appear. So what is your conclusion?
The inference here can point out through that the swelling which was appearing was probably entering through the deep ring. So thereby, when deep ring was occluded, it did not
Hmm.
appear out. Probably the site of origin was not from the medial side. It was through the ring.
Can you just tell me briefly about deep ring? Where is it situated and how
Deep
is it?
ring it is an opening in the fascia transversalis, which
Hmm.
is 1.25 centimeters above mid-inguinal point.
Okay. What type of hernia occurs to deep ring?
And indirect inguinal hernia occurs.
Direct?
Direct occurs through the Hasselbalch triangle.
Yes. Can you tell me the boundaries of Hasselbalch triangle?
Where, medially, it is outer border of rectus sheath, and laterally inferior epigastric artery, and lower inguinal.
Siemens technique?
I saw. In Siemens three-finger technique, where we have to place the left hand, the index finger over the deep ring, middle finger over the superficial ring, and ring finger over the saphenous opening. Then the patient was asked to cough, and the impulse was felt at the deep inguinal ring. That was the impulse was felt in the index fingers.
This was done standing or lying down position? Supine.
Uh, this was done again on standing, sir.
Mm.
First,
Next.
and coming to the ring invagination test, this was done in the lying down position, where after reducing the swelling, we have to invaginate with the left little finger into the superficial inguinal ring, and we have to move upward and slightly medial to it, thereby facing the pulp of the finger towards the medial side. So whenever the a patient was asked to cough, the impulse was felt at the tip of the little finger, which again suggests the origin of indirect inguinal hernia. So,
Good.
then
Next. Continue.
coming to the parietal examination, there was no enlargement felt. So, was to probably to rule out any benign prostate.
No enlargement of what?
There is no enlargement felt. So there was, whenever the prostate we were examined.
No, see here you'll have to look for genitally everything.
Yes,
Did
sir.
you look for any stricture,
Ah,
urethra? Did you look for any phimosis? Did you look for any? Yeah, continue.
yes, sir. I was for parietal examination was probably is usually done to rule out the benign prostatic hypertrophy or.
How did you look for BPH? Tell me.
So by examining the prostate,
How?
uh, parietally when you invaginate, where
Hmm.
for the prostate in the anterior, whenever there is enlargement felt, we
What is
can.
the position of the patient when you're doing a rectal examination? Did you do it?
No,
No. You're not done.
no.
Hmm.
Lie prone
This is how you get caught. No? Left lateral position. Yes.
whenever they're lying
Then
down,
upper lip flex.
lefty op same side, they have to let more so that.
Have you done okay? Have you done rectal examination otherwise also?
Sir, I have had none, so I have known.
No, you people should do, man. You should do it in the odds rounds. No, you should ask at least. If you don't do when you're not getting a chance, ask them to do. I mean, ask somebody. They'll teach you
Yes,
because here there are so many things that you should look.
yes.
What are the things that you should look for?
The stricture of the urethra, as you said, sir, we usually
Not. Uh,
feel over the base of the
no, I'm
stroke.
asking at per rectal examination.
Mm,
Lobes.
uh,
Yeah, tell.
not sure, sir.
Please read and
Yes.
do it. You have to look for the median groove obliteration, left lobe, right lobe, whether it is hard, firm, and whether you are able to reach the upper border or not. So these are all the signs of prostatic enlargement. Of course, see, nowadays you're used to sending them directly to ultrasound and ask for post-residual volume and then come to a conclusion. No, you should be able to do that.
Yes, sir.
Yes. Next. No, genitalia you have to examine. This is very important because why do you think rectal examination is important here? Why are you bothered about hypertrophy of prostate?
Sir, usually the age here is around 50 years. So, according to the prostatic changes, based on the age, they are prone for having benign prostatic hypertrophy.
Okay, but why are you bothered about prostate for hernia?
Sir, as I mentioned earlier, because whenever there is hypertrophy of prostate, there can be a bladder outlet obstruction, which can again lead to urinary retention and straining on training while maturating.
Okay, later on, what happens? During treatment also, what happens? Suppose hernia is there, you're done our surgery for hernia, finished.
Yes. Again, there will be
Can it
recur.
recur?
Yes,
Yes.
we have
So
to
you'll have to go for
same sitting. First, we have to do the
no.
prosthetic.
You have to tackle the prostatomegaly also, isn't it?
Yes, sir. First, we have to tackle it, and then
Otherwise, again, it can recur.
yes, sir.
So this is an important thing. Then again, you have to timing of you are already, come prepared. Timing of surgery, whether you should do it later or at the same sitting. It can be done now at the same sitting.
Yes.
Yes. Next.
Per question, sir. Resonant note was heard over the swelling, and on auscultation, bowel sounds were made out. And other system examination where CVS normal S1 S2 heard, there was no murmurs heard. Respiratory, no normal vesicular breath sounds heard, there is no adventition sound. And on GIT per abdomen examination appears soft. And on CNS examination, there was no facial asymmetry or all reflexes are normal.
Abdomen, would you like to see something?
Sir, on inspection, when stars or that was made out. And
Not
other,
what? Only scars. Scars because why?
yes,
Scars.
previous hernial surgery was done to rule out that previous.
No, not only that. What happens when there are surgeries? There is weakness.
Weakness, sir. There can be
And one more thing. What do you look for?
mass, and again any mass.
Okay.
And in case of obstructed hernia presentation can also be like can be severe.
What are malgagnis bulgings?
Sir, this is whenever it is usually seen in elderly where there is a weak muscle tone. So thereby, while lying down, if the patient is asked to raise his head, there can be bulges seen, which represents the poor tone of
That,
the abdominal muscle wall.
so what will your plan of treatment be? It will change, isn't it?
Yes, sir.
What would be a plan of treatment if there are weakness of abdominal wall?
So, I would rather prefer for the surgery for annuloplasty rather than annuloplasty. So,
Yes. So you may have to go for mesh repair.
shall I proceed, sir?
Yes, proceed.
Provisional diagnosis. This is a case of left-sided incomplete, reducible, indirect inguinal hernia containing intestines without any complications at present.
Would you like to give a differential diagnosis or you would like to stick to this?
Sir, as of now, I'll stick to this.
Yes, you should not. This is a diagnosis you've made and you cannot give any differential diagnosis because all these signs and symptoms are of hernia. Yes. I would request others also to.
Hello.
Hello, yes?
Yeah.
Madhu? Kelly, Madhu?
Ready? Yeah. Nothing. We are all basically. One second. Start my video. I am basically a freelancing surgeon. Not very much acquainted in guiding the students for examination.
Angala?
Yeah, that's
just
way.
Your questions and listen to
Yeah. As far as UGs are concerned, definitely there will be some stock questions.
Yeah. Most of them we have asked, I think.
Yeah. Every step in case presentation is very, very important for all the students. For every question, there should be a reason for that. Your way of presentation, what I feel is the way of presentation and basic stock questions and answers, you need to get ready.
Yes.
Don't worry about too much of advancements in surgery or medicine, whatever it is. Basic question, history taking and in history taking, and every question for which you ask, there should be reason for that. It should not be a routine thing, what I feel. And even examination also method, I feel examiners go and observe your methodology of your examination and history taking rather than your diagnosis, your knowledge, and the approach is very, very important. What I feel. Ready, am I right?
Completely agree.
Yeah.
See, as an undergraduate, we wouldn't want you to make a great diagnosis and treatment and all that. We are not bothered at all. You make mistakes, fine. But you should know the basics of what you're doing. That is all. And you, like, see, for example, you did not do a rectal examination at all. So there is a need for doing a rectal examination. Just you should know that you have to do it. For UG, that is all we are asking. We are not asking you to go into the depth. The way you're prepared now is really excellent. With this, you'll definitely pass. And maybe you'll get good marks also. What we have presented now. Dhanush.
Yeah, Dhanush.
So I want all the cases to be prepared like this. So that you are ready to present and answer at least the basics of surgery. We wouldn't want to go see complications. There are so many things. Now, again, complications. Then again, we'll go into the depths of how you repair. What is the surgery you would want to prefer? Yeah, what is the surgery that you would prefer for this case?
Sir, for the management, we would prefer licensing tension-free mesh hernioplasty, sir.
Why hernioplasty? Why not herniorrhaphy? What do you mean by herniorrhaphy?
Yes, sir. The difference is the procedure where herniorrhaphy is done for the good muscle tone, whereby it can be by the young patients who have good muscle tone. But in case of elderly male or elderly, it can be repaired through hernioplasty where the mesh is used. Thereby, the fibrous growth over the mesh can make the wall or
It's
the
a foreign body. See, those again, now again, Bessenis repair and all that. Bessenis repair is already, I mean, nobody does it now. Everybody straight away, we go starting with hernioplasty. We use a mesh and hernioplasty is the treatment that we use. And again, we have other forms of treatment like laparoscopy, tap and tap and all those things, which is a big advancement over what we used to do earlier. Right. At least you should know the basics. Yeah. What is then when?
Yes.
Right. What else? What are the other forms of treatment that you know? And you told you have to tackle prostate also at the same time. Yes, very good.
Sir, usually in congenital hernias, we
Mm.
usually prefer herniatomy because the superficial ring and the deep ring are superimposed. There is no proper inguinal canal. So thereby just cutting open the sac and pushing the contents and removing the excess sac is enough, sufficient in case of herniatomy. But in case
In whom?
children's, like
In
whenever
children. So what you would try to tell is inguinal canal is also not well developed, isn't it? Superficial and deep ring is almost over it. So there's no canal there for you to do hernioplasty. It is herniatomy only. Hmm.
in case of herniorrhaphy, as I earlier mentioned, the in case of a good muscle tone, you can go with the herniorrhaphy so that just the suturing of the conjoint tendon with the inguinal ligament can bear enough the deficient opening there. But in case of a poor abdominal tone, you can go with hernioplasty where mesh is used, where there's a foreign body reaction, thereby it supports both the defective wall and the protrusion in the futures.
And again, what you told, it is tension free. That is very, very important. Like what do you advise the patient? Or what are the complications of surgery?
Sir, in complications of surgery, most common nerve injured is ilioinguinal nerve, and most common nerve which is entrapped is iliohypogastric nerve. So there can be paresthesia over the region supplying the nerve supply, sir. And
Not only paresthesia, there can be severe pain.
severe burning type of pain can be. And hemorrhage is also a complication in surgery. And again, there can be, if there is no proper um, whenever there is no proper correction of the precipitating factors, there can be recurrence of the hernias.
Okay, good presentation for UG. Hmm. Dr. Madhu, anything more?
Ready?
Hmm.
Nothing that way.
Okay.
A student should carry the what do you call that?
Message.
Yeah, message like they need to present in a very, very, very methodical way. That is the only
Methodical.
thing examiner
Yes.
expects, rather than diagnosis, rather than treatment part, and some basic things they need to know, like why they do routine investigation. They need to
Exactly.
rule out the diabetes. Other systemic causes also they have to rule out. Those things they need to know. The students are listening, you know. Dhanush?
Yes, sir.
Correct, sir.
Yeah.
Yeah.
Audible, sir.
Yeah.
As
Overall, it was a
usual,
good
this
presentation.
is yeah, it was a good presentation.
Yeah, ready. We can give some tips to other cases also, then we can wind up. Any students
Yeah.
can ask questions. Krupa?
Any questions
sir?
you can ask?
Yeah, you can, the forum you can just open. Other students also can participate.
If any students have any questions to ask to sir, you can unmute yourself and ask the question.
All are intelligent, I feel.
I think it was done really methodological way, sir. Really happy with the case presentation.
Yeah, he has
Every
done a good
point has
job.
been yes.
Yeah, you can stop screen sharing, Dhanush.
Dhanush, you can stop screen sharing.
Yeah.
So the way you're presented now, as an undergraduate, if you can take all these cases which are there for exams,
Yes.
if you prepare like this is enough for you to get first class cut. You'll score very good.
Yes.
Because
Thanks.
you knew the case earlier, I think you prepared for almost a week or so. Yeah? So I'll take out all the exam cases, discussion. I always tell discuss.
Yes.
Go on the rounds, discuss, and go back and read. That's all is required.
So
So we
there
have a student called Swati who has asked a question in the
Yeah.
chat box. The question
Yeah,
is why we ask for deviation of penis, sir?
that is actually not required. That's the reason why I asked him also. You don't have to see. Suppose it's a hydrocele, huge hydrocele, it will be shifted left or right. It doesn't matter at all. This is a question asked even during our UG days. I don't know why that is come into the book. Probably a huge hydrocele is pushing the penis to one side. That is the only reason. But it doesn't have any significance towards your treatment.
Thank you, sir. I hope, Swati, you got the answer. And next question is from Anup Sarang.
Yeah.
He's asking, good evening, sir. Could you please explain the exact reasoning for calling it tension-free mesh hernioplasty?
Tension-free. See, for example, you are doing a Bassinis repair. Earlier, what we used to do, a Bassinis repair or even anatomical repair, there is usually tension when you are approximating the layers. So when there is tension, there is chances of injury, there is chances of blood supply getting compromised, and again recurrence. That was one of the big reasons for recurrence of hernia after surgery, even when you have done very well, when you are very satisfied. With this mesh, what you are using, there is absolutely no tension. You're just placing a mesh there, securing it to the edges so that there is only foreign body reaction and the wall is tight enough. So there's no recurrence. That's all. That's why we call it tension free.
Yeah, anything?
No, sir. These are the only questions that were asked. Prasanna, can you give the vote of thanks?
Yes,
Krupa,
ma'am.
Yeah,
you
please
don't
start.
have any doubt?
No, sir. No, sir.
You are also exam going, you know?
Sir?
You are also exam going, final.
Yes, sir.
Yeah.
I have no doubts. I think all the specific points were being touched, and yes, sir.
One thing before I can conclude, because I would like to tell all students here, for not only clinicals, for your theory also, please read Bailey and Love, which is the prescribed standard book for your exams. Your question paper is based on the latest Bailey and Love. I cannot elaborate more on that, but this is the book which is prescribed and questions will be asked from the 28th edition of Bailey and Love.
Yeah, that is the Bible for us.
Yes.
Earlier.
Now we use all other books, but for your theory passing, I am giving you a clue. Please read 28th edition Bailey and Love, which was released somewhere 3 years back, I think. The latest edition.
Our professor, probably anatomy, Ramesh Reddy, if you remember, Dr. Roosevelt used to tell.
Yeah.
I still remember his words, like what is surgery? It is anatomy and common sense.
Exactly.
Yeah, you need to know the anatomy and never think the UG, if you get an hernia case, it's easy. Hernia is a, what do you call a spot diagnosis. But the questions attached to it, the history taking, every questions, everything that is related to the hernia, anybody can fail you. Even as a PG, if you get a hernia case, it is a nightmare for the students, PGs to pass. They can take you anywhere.
We did not go to PG questions at all. We were sticking there to UGs only.
Yeah.
If you had to start that, it will be very difficult.
Yeah, that's what I said. I told them, hernia is easy for UG to pass, difficult for PG to. Yeah, you can conclude.
Prasanna, you can start with the vote of thanks.
Yes, ma'am. So thank you so much, sir. Actually, extending a warm thanks to Dr. Ramesh Reddy, sir, for addressing the webinar and sharing the wealth of knowledge with us, sir. And I would like to thank Dr. Subhata ma'am, Dr. Madhusudan, sir, Krupa ma'am, for addressing. Thank you. Have a great evening.
I would like to thank Dr. Madhu for giving me this opportunity and all IME members who are part of this for really giving me an opportunity and bringing me here. Thank you so much and wish you all a happy new year.
Thank you, Reddy. For in spite of your busy schedule, he was about to cancel this.
My pleasure.
I'm very grateful to you. Thank you very much.
Thank you, sir, from MSN. Thank you.
Thank you.
Tomorrow, all the students kindly join for medicine case presentation. Krupa.
Yes, sir. It will be circulated.
Yeah. Okay. Thank you. Bye. Good night.